Medurstand-Understanding Medicine.
I am Professor Aziz-ur-Rehman. In the last video, we discussed basic concepts about pneumonia. We discussed the definition, etiology, classification, clinical features, and basic labs. And we are going to continue in this video, the second part, and this is going to cover diagnosis, prognosis, and the treatment. And at the end, we will have a few slides, which is a kind of revision of the whole module. Diagnosis, in my opinion, is quite easy. If you take the case of pneumonia meticulously, the diagnosis is usually very obvious. Now, there are various types of pneumonias, but I'm going to discuss mostly the community-acquired pneumonia. The diagnosis is based on history. A patient typically presents with a high-grade fever with cough. Now, typically, there is one episode of rigors and chills that is followed by continuous temperature. And the temperature won't go unless one takes paracetamol or ibuprofen or some other antipyretic. The temperature is usually continuous. It is usually associated with dry cough. Unless patient has some coexisting or pre-existing lung condition like asthma or COPD, usually the presenting cough is dry, and there may be associated pleuritic pain based on which lobe of the lung is involved. There may be pleuritic pain and which increases on coughing. Then there may be signs of consolidation. If you examine the patient and if the patient has got developed consolidation at the time of presentation, you may find the signs. Initially, there may be crepitation, followed by bronchial breath sounds, agophony, reduced percussion note, dull percussion note, and vocal fermitis and vocal resonance may be increased, and there may be agophony. So these are the signs of consolidation. So later on, there will be again crepitations. If you do CBC, CBC is very important in all patients with pneumonia, and CBC will typically show neutrophilic leukocytosis with shift to left and maybe presence of band cells. Unless patient is immunocompromised, this is the typical response in these patients. And then opacity on X-ray. If you do an X-ray test, which is I think very important in all patients with pneumonia, X-ray test will show various types of opacities. Typically, it will be consolidation involving a particular lobe. It may be right middle lobe or upper lobes or the lower lobes or multiple lobes. In case of bronchopneumonia, there may be multiple confluent shadowing. All these things were actually discussed in the last video, but here I'm just going to present you the summary. These are 4 things which should be considered before making a diagnosis of pneumonia. I think based on this, you should easily be able to make a diagnosis of community-acquired pneumonia. The prognosis, pneumonia is potentially a serious infection. It could lead to complication. And I think most important thing which determines the morbidity or mortality of the prognosis is not the pneumonia itself. It is these features: demographic factors, comorbid illnesses, physical examination findings, and laboratory and radiological findings. These criteria are based on Pneumonia Outcome Research Team, abbreviated as PORT. So these 4 should be considered to determine the prognosis. I'm not sure how important these factors should be in one given individual. Whenever you see a patient, of course, your aim is that this patient should recover. These things, they are applicable to communities or when we do the public health, but in one individual, you should consider every person a potentially serious person and you should give the best possible treatment. Respiratory tract infections are common. They get better even without treatment, but pneumonia is not common, and if somebody develops pneumonia, it is actually potentially serious, so you should do your best to save this patient. Now, very briefly, I will not go into the details because I think that will take me beyond the scope of my lecture. So I will very briefly mention these four things. First of all, the demographic factors, you have to consider whether the person is male or female, and accordingly you give a certain number. So for men, just give the number of years as age. For women, number of years minus 10, and for nursing home residents, you give 10 points. All these points actually add up to give you the final score, which determines the prognosis. Now, this is another thing, prognosis based on port scoring system. The second part is comorbid illnesses. Now, what are the comorbid illnesses? In this patient, if somebody has a neoplastic disease, malignancy, or patient has got liver disease, patient has got congestive cardiac failure, patient has got CVA, patient has got renal disease. All these conditions, they themselves have poor prognosis. If somebody with pneumonia have these conditions, then prognosis will become worse and these numbers will be added. Somebody with neoplastic disease, you will add 30 points, liver disease 20 points, and in the rest three conditions, just 10 points. These points will add up to give you a final score. Then third is physical examination finding. In physical examination, if patient has got altered mental status, he gets 20 points. Respiratory rate more than 30 per minute, 20 points. Systolic blood pressure less than 90, that means patient is already maybe getting into shock, 20 points. Temperature less than 35 or more than 40. Now this is important. Somebody having temperature more than 40, that carries poor prognosis, and somebody whose temperature is low, hypothermic patient, he or she also has poor prognosis because that patient gets 15 points. Pulse more than 125 per minute, that also gets 10 points. It is actually usually possible without specifically giving these points. Usually I think by general sense it is possible to tell the prognosis, but if you want to be more meticulous, you can adopt this system. Then the last thing is laboratory and radiological findings. In this, if patient has got pH of less than 7.35, he gets 30. BUN of more than 30, 20. Sodium less than 130, 20. Glucose more than 20, 10. Hematocrit less than 30, 10. Arterial blood gases, partial pressure for oxygen less than 60, 10. And pleural effusion, 10. So actually, aim is not to memorize these things, but just to have some idea that these are the parameters which determine the prognosis. So you could actually refer to different apps. This is available in app also. If you see many patients of pneumonia, maybe you can use this app to determine the prognosis in individual case. Now this is the total risk. So from all four parameters, you calculate the score, and if somebody has more than 90, these patients must be admitted to the hospital because they carry poor prognosis. They would surely need oxygen, they would surely need IV infusion, they would surely need IV antibiotics combination, and this kind of treatment can only be offered in hospital. Those patients whose score is less than 70, they can be managed as outpatient cases, and that means they will be given oral antibiotics. They usually do not need supplementary oxygen and suction or things like that. Of course, there is a category where you could decide either way, patient depending upon patient preference. We have to consider patient preference also. Somebody who is not that sick, the person here, that patient may also sometime prefer to be admitted to get a better care. So, and these patients may be admitted or can be treated as outpatient. Complications, pneumonia, there may be smooth recovery if there is smooth recovery, that also takes about 2 to 3 months. Typically, initially the symptoms go, like fever goes, cough goes, chest pain goes, but patient continue to expectorate because that consolidation is resolving. And it, I think, takes about 12 weeks before patient is completely recovered. And the final test for recovery is resolution on X-ray. But sometimes patient may end up in complications. And let me give you a brief account of those complications. First is pleural effusion. Little bit of pleural effusion on X-ray or on ultrasound of the chest or CT of the chest. I think little bit of pleural effusion is probably a part of pneumonia. But if patient develops large amount of effusion, that would be called parapneumonic effusion. This is also of two types. When I say pleural effusion, I am actually referring to the first type where there is almost sterile fluid in the pleural space. But then there may be purulent like pus in the pleural space, that would be called empyema. What is the difference? This is clear fluid like normal body fluids, but this will be pus like fluid. When you tap them, and I think in both these cases, if there is large pleural effusion and if there is empyema, we need to intubate, we need to put a chest tube, and particularly in empyema. If there is empyema, we need to take this fluid out because it would be very difficult to resolve within the body. So I think it is best taken out by chest tube, and then of course patient is on antibiotic also. Then lung abscess. Normally pneumonias, they resolve and ultimately the underlying lung becomes exactly normal mostly. There may be very little bit fibrosis or bronchiectasis, but most of the lungs look normal on X-ray. But some individuals, particularly those who have pneumonia secondary to foreign body inhalation or obstruction of the bronchus or lung cancer, or those who are immunocompromised, they may develop lung abscess. Lung abscess is another serious complication, and it usually does not require drainage because it drains on its own, but patient should be helped by chest physiotherapy to help this drainage, and these patients also they have prolonged protracted illness. Septicemia and shock. The usual pneumonia, the streptococcal pneumonia, they have certain polysaccharides in their cell wall, and they just act like endotoxins. And this is one of the few gram-positive organisms which can cause endotoxic or endotoxic-like shock. These patients may develop hypotension, or then they may go into multiple organ failures. So you surely do not want those patients who develop low blood pressure, they should be treated aggressively, and those who have developed shock, they should be given the best possible treatment. Then of course, treatment goes beyond antibiotic and pneumonia, then you have to treat shock. The prognosis is accordingly relatively poor. Respiratory failure, we have lot of lung reserve. If one lobe is involved, that if the remaining lung is otherwise normal, patient would develop little bit of hypoxia but no hypercapnia, no respiratory failure. But if large part of lung is affected and if patient has got underlying lung disease, there is a possibility that the patient may develop type 1 or type 2 respiratory failure. If patient develops respiratory failure, the prognosis will become very serious, and these patients would require ventilation and hospitalization into and admission into ICUs. So respiratory failure, which is defined as either hypoxia alone or hypoxia with hypercapnia, that is, I think, very serious complication. Death, of course, any of these conditions, if not controlled properly, and then that could result into death also. So very serious outcome of pneumonia. The choice of antibiotic, let me first give you one I think information that we mostly in our community especially, antibiotics are wrongly used. Antibiotics are prescribed to patients, those patients who actually do not need antibiotics. They have just little bit of viral infection. Even if there is some bacterial infection, they should recover on their own, but antibiotics are wrongly prescribed. Many times antibiotics are self-prescribed by patient. When patient come to us, they're already on antibiotics. So then we are sort of under pressure to continue them. But pneumonia, especially the lobar pneumonia, is one condition where antibiotics are extremely essential, because this is a very serious type of infection, usually bacterial, and I think antibiotic is definitely indicated. Not only antibiotics are indicated, antibiotics should be given in combination, usually, because at the time of presentation we do not usually know the causative organism, so we have to cover multiple possible pathogens, so it's usually combination. And number two, it is usually given in the high dose. Within the recommended range, we usually give the high dose. And number three, the duration must be appropriate. I think 7 to 10 days minimum. Patient would continue to have symptoms after that also, but I think 10 days minimum antibiotics should be given. Of course, in some cases it may be longer. Now, these are the antibiotics. I think what is the rationale of combining? Because community acquired pneumonia could be due to strep pneumonia or mycoplasma. Okay, so and there is no easy way to differentiate, and there are no definite radiological findings, although there are some which may suggest one or the other, but many times you're not sure. So I think best practice is to give a combination of antibiotic, one from penicillin and the other from macrolide groups. So this will cover strep pneumonia and this will cover mycoplasma. You know, mycoplasma does not have a cell wall, and penicillins, they work on the cell wall. So penicillin would not work in case of mycoplasma. If you are sure that this is just strep pneumonia, only then penicillin may be enough. If you're sure this is mycoplasma, maybe you can give just the macrolide. But since mostly you're not sure, I think it is best to give a combination. Amoxicillin 1 gram 3 times a day, orally or intravenously. If patient is sick, then intravenously, otherwise orally. Or you could give amoxiclav 1.2 grams TDS. What is amoxiclav? It is, amoxicillin plus clavulanic acid, which makes it effective against methicillin resistant strains also. So I think out of the two, amoxiclav should be better. Now plus, this is plus clarithromycin. Clarithromycin is available either 500 milligram 3 times a day, or you could give azithromycin 500 milligram twice a day. So combination of a penicillin based antibiotic and macrolide combination, I think this would be very good for 10 days. Patient will develop some GI upset, and patient should be counseled that this is very essential. Those who do not tolerate oral antibiotic, they may be switched over to injection, but oral, I think they work pretty well. Then alternate antibiotics. If somebody is allergic to penicillin or somebody cannot tolerate these medicines, then maybe alternate moxifloxacin 400 milligram OD. This is a great antibiotic because this is actually effective against strep pneumonia and also against mycoplasma. So one antibiotic, moxifloxacin, can be given, and the dosage is also once a day, in some cases maybe twice a day. Another advantage of moxifloxacin is that oral and IV doses are bioequivalent. That means initially, if patient is very sick, admitted, we may give intravenous moxifloxacin, and when we discharge the patient, we can simply switch over to oral, same dosage, and we expect the same response. 400 milligram intravenous and 400 milligram oral would have the same effect. If patient can take oral medication, then I think oral should be better. Levofloxacin is another alternate. These are called third generation respiratory quinolone. So based on the availability of antibiotics and patient preferences, patients' culture reports if available, I think one of these antibiotics can be given. But lesson is antibiotics should be given preferably in combination, preferably in high dose, preferably for long duration, 7 to 10 days. And during that, we monitor the patient for any complication of pneumonia. Then pneumonia, of course, is the mainstay of the treatment, but then there are many other things we give to these patients. Antipyretics, usually in the form of paracetamol, or you could give ibuprofen or naproxen sodium. Analgesics, same, or antitussive. Patient may have cough, so we'll give antitussive cough syrups to suppress his cough to just ease out his illness. Now, one question, should we give cough suppressant or expectorant? This is actually often discussed. Of course, patient with pneumonia needs to expectorate, but that is only after several days of onset, after several days. Initially, it is just dry cough. If patient has got a dry cough, I think cough suppressant, those which contain dextromethorphan, they could be given to ease out the cough. Once patient starts expectorating, then maybe you can give some expectorant to help him cough out maximum amount of sputum. But you know, when pneumonia is resolving, it is because of the proteolytic enzymes produced by neutrophils. They are much more potent expectorant than any drug. So those patients probably would not need any expectorant, but I think based on individual experience, you can give either one. You have to make sure that patient takes good nutrition and is well hydrated, and then treatment of complication. Whatever complication patient develops, then you should give the treatment. Like I gave you the example of empyema. If there is empyema, then chest intubation would be needed. So this was the treatment part. Many other antibiotic regimens may be needed. Now, what I mentioned is about community acquired pneumonia. Based on settings, if it is hospital acquired pneumonia, the choice of antibiotic will be very different. If this is ventilator associated pneumonia, choice of antibiotic will be different. If this is pneumonia in a neutropenic patient, HIV patient, the choice of antibiotic will be different, empirical. Then sensitivity pattern in community. Now, you may not know the exact culture sensitivity pattern that individual, but many times we know the general pattern in a community. So if we know that majority people in our community are resistant to penicillin based antibiotics, then we might as well give respiratory controls or other antibiotic. Then in one individual, if you have the culture report, at the time of presentation, it is the blood which is cultured, and later on, once patients start expectorating, maybe we can culture sputum. But if patient is already on antibiotic, then probably sputum will not yield any growth. But if you have the culture report in that individual, then antibiotic should be based on that report. So there is no single regimen which will suit every person. Based on setting, sensitivity pattern in the community, or the sensitivity pattern that particular individual, you will choose a particular antibiotic or combination of antibiotics. Now, can we prevent pneumonia? Of course, we can prevent pneumonias. Other than general health principles, one should not smoke and one should have good hygiene, good quality of air if that is possible. That is one thing, but pneumococcal vaccine is available. Now there are two vaccines, 23-valent polysaccharide vaccine. This has been available for quite some time, maybe 2-3 decades. This is very effective. It covers 23 different strains of streptococci, which are commonly responsible for pneumonia. But then later on, there is another one added. This is 13-valent conjugate vaccine. Now this is modified, and uh, due to conjugate technology, the penetration of bacteria is much better. So you get better immunity with 13-valent vaccine as compared to 23. This gives you broader coverage. This gives you deeper coverage. So it makes a good sense to take both vaccines 6 months apart. Everyone? No, I don't really think. There is actually a specific indication. Elderly people, people with COPD, people who have this underlying lung disease or immunocompromised, they may be given these vaccines. I think every adult person does not need these vaccination because uh, chances of getting pneumonia in lifetime is low, and if you do develop pneumonia, the chances of responding to antibiotic is quite good. So I don't really think that there is a case for universal vaccination with these vaccines, and these are pretty expensive. Usually once in a lifetime is good enough. So if somebody has taken 23 valent, maybe he can take now 13 valent, and that would be good for life. Now, as I said, we have covered this module, but in the form of this true and false exercise, we are going to revise what we discussed in these two videos. Very quickly, I'll go through, and if you want to do this exercise, you can slow down the video and run it at a slow speed, and maybe you can do this before I give you the response. Most lobar pneumonias are viral in etiology and do not require antibiotics. True or false? In my opinion, it is false because lobar pneumonias are usually bacterial and I think should be treated with antibiotics. Pneumonia is a serious type of respiratory tract infection with mortality of up to 30%. Depending upon the condition, I think in community-acquired pneumonia, mortality should not be 30%, but those patients who are hospitalized, hospital-acquired pneumonia and ventilated pneumonia, the prognosis could be bad and it could actually exceed 30%. Many host factors are important contributors to morbidity and mortality. Very true. Cell wall polysaccharides may induce endotoxic shock. Yes, I told you because these act as endotoxins and they cause vasodilatation and cause abnormal distribution of fluids, and fluid leaks into the third space and it could definitely cause shock. Absence of physical findings rule out pneumonia. Pneumonia, especially the lobar pneumonia, has got typical findings on inspection, palpation, particularly auscultation and percussion. So statement is, if you do not have these findings, that rules out pneumonia. No, certainly not. It depends how experienced you are, and also even for an experienced person, a deep lesion could be missed on auscultation. So I think if somebody has high-grade fever and pleuritic pain, then I think an X-ray is definitely needed to rule out pneumonia. You can't rule out pneumonia if the physical examination does not reveal typical finding. The investigation of choice for the initial diagnosis of pneumonia is sputum examination. In my opinion, this is not the correct statement because at the time of presentation, most patients do not expectorate. They just have dry cough. So at that time, I think blood culture may be possible. Physical finding may vary depending upon the stage of disease. Of course, consolidation passes through various stages. So you may have crepitations and then you may have bronchial breath sound and finally again crepitation and reduced breath sound. The choice of antibiotic should always be based on sputum culture sensitivity. That is not possible because many patients, they do not expectorate. So we have to start antibiotic on empirical basis and later on maybe sputum can be cultured. If sputum is available, then of course culture would give you very good information about the choice of antibiotic, but most patients, they have just dry cough. In majority of the cases, lobar pneumonia will cause significant shift of midline structures on X-ray. In majority of the cases. Now, this is not correct statement. In pneumonia, alveolar air is replaced by exudate, and there is no increase or reduction in volume. So these are two things which actually lead to shift of midline structure. Although in some patients there may be underlying collapse because of some bronchial obstruction, or there may be parapneumonic effusion or empyema. In these patients there may be shift of midline structure, shift of trachea, but not in majority. In majority, even on X-ray you would have trachea in the midline. Antibiotic must be continued till the normalization of X-ray. Again, not true statement, because X-ray typically takes 10 to 12 weeks to become 100% normal. So a check X-ray is needed. If patient is not feeling better, patient not improving, then maybe earlier on. But if patient is improving satisfactorily, I think all patients should have a check X-ray after 12 weeks to make sure that patient has actually completely recovered. And antibiotics are usually not needed for that long. Antibiotics are usually needed 7 to 10 days if the recovery is satisfactory, and opacity will continue to persist. Some other symptoms will also continue to persist, but antibiotics are usually for 7 to 10 days. Blood culture may reveal the organism earlier than sputum does. Yes, this is a true statement, but only about for 50% of the cases. Persistence of rigors and chills indicate the development of complication. This point I explained in the last video. In simple uncomplicated community acquired pneumonia, there is one episode of rigors and chills that is followed by continuous high grade fever. But if these rigors and chills are recurring, then it could indicate either a complication of pneumonia like pleural effusion, empyema, or lung abscess, or it could indicate some specific etiology. It may be Klebsiella. Klebsiella can cause this kind of pneumonia. So true and false, an underlying cause must be ruled out in following conditions. If somebody who's very young develops pneumonia, somebody who's very old develops pneumonia, smokers, recurrent pneumonias, failure to resolve, consolidation with collapse. I'm not sure if I should use the word must, but I think should. It should replace should. So all these patients should have underlying disease ruled out, just to be sure that we're not missing on anything. In community acquired pneumonia, it is advisable to cover main pathogens on empirical grounds. Yes, strep pneumonia and chlamydia both should be covered. Unless you have a specific etiological diagnosis, both should be covered, and I told you how to cover both organisms. Identification of the etiological organism is important, since this is the key to the appropriate antimicrobial therapy. If possible, not in everybody. It is not possible in everybody. You know, in majority, even in developed societies, in at least 50% of the cases, you never know the exact etiology. I'm not sure if it is 50%, but in good percentage, you actually never know the exact etiology. Yes, this specific microbial etiology remains elusive in more than 1/3 of the cases. So it is 1/3 number. That is true. The prognosis of hospital-acquired pneumonia is good due to early diagnosis and treatment, because patient is already in the hospital, so there is a chance of early diagnosis and early treatment intervention. The prognosis is good. Is that right? No, it is not. Because the organism, number one, patient is in the hospital for some reason, so that means patient is already sick. Number two, patient develops pneumonia due to hospital bacteria, and hospital bacteria are always very resistant. So even if there is an opportunity of early diagnosis, early treatment intervention, but these patients have relatively poor prognosis as compared to community acquired pneumonia. Polyvalent pneumococcal vaccine is recommended for all adults to prevent pneumonia. I think this is not a correct statement. Only specific people, elderly people, diabetic patients, immunocompromised, and those patients who have underlying lung disease. Occupational history may give important clue to the causative organism in pneumonia. Yes, I think in some cases, if you take occupational history, that can give you some important clue to the etiological organism. I think I have another slide for this. And this is it actually. Now let's match the age with etiology. So these are the age groups and this is etiology. And let me see if you can figure out. Chlamydia, trachomatis, and respiratory syncytial virus. In which age group? Infant less than 6 months. Chlamydia, trachomatis, or respiratory syncytial virus. H. influenzae. Children 6 months to 5 years of age. Mycoplasma pneumoniae and chlamydia pneumoniae in young adults. H. influenzae and Moraxella catarrhalis, elderly individual with chronic lung disease. This is just a rough idea. Of course, there is an overlap. Thank you very much. This has been Professor Aziz-ur-Rehman from Medurstand. I hope I was able to give you a good account of how to diagnose and treat pneumonias and the complication and the choice of antibiotics. So I really look forward to see you in my next video on another illness on respiratory disorders, and I think we'll cover lung cancer maybe in the next slide, or maybe pulmonary fibrosis, something like that. Thank you very much, Professor Aziz-ur-Rehman from Medurstand.